we can probably get started here, maybe 30 seconds early, if that's okay. I have a feeling we're going to use all 40 minutes of our time here. First of all, let me thank everybody for joining us today. Get to see some lots of familiar faces in the room, which is really wonderful, and a lot of new faces. So really is an honor to have you all here. So our panel today is really going to focus on alignment. This is something that I think is a real opportunity here in the United States and the U.S. health system. One of the things that I talk about a lot is when I think about innovation in the United States, when it comes to healthcare, we've been extremely successful at innovating around disease management, right? I mean, if you have a complex cardiac problem, you go to a guy like this, Doug Johnston here, you're going to get the best care in the world. But we have not innovated when it comes to healthcare delivery. And I think that's really our opportunity. And a big part of that, in my view, has been kind of a lack of alignment between the physicians, the healthcare systems, and the payers. So how can we improve that? What's our present status today? And what's our future state when it comes to that alignment? So we've worked really hard to put on a great panel, bring everyone together to talk about this. And everyone here kind of wears a bit of a different hat. So I think you'll get a lot of different perspectives, which I think will be really interesting and really exciting. So again, thank you for being here. I'm Wael Barsoum. I'm an orthopedic surgeon. I spent 25 years with Cleveland Clinic, first up in Cleveland. And then the last 6 years of my Cleveland Clinic career were in Florida, where I was the CEO of Cleveland Clinic, Florida, while still being an active orthopedic surgeon. 4 years ago, I left. I joined HOPCo, Healthcare Outcomes Performance Company, as the President and Chief Transformation Officer. Jason, do you mind introducing yourself?
Yeah, thanks, Dr. Barsoum. So I'm Jason Sansone. I'm a spine surgeon, practicing spine surgeon in Madison, Wisconsin. Run a private, fully independent group of 12 and soon to be 14 physicians that is subspecialty across orthopedics, as well as bringing on pain management. And it's great to be here. I feel like I'm definitely the one with the least credentials up here, but I will do my best to hang in there.
We brought you up here for the height.
Yeah, exactly.
Okay.
Hi, I'm Doug Johnston. I'm probably the outlier. I'm the cardiac surgeon here in Chicago at Northwestern Medicine. I started my career in Cleveland Clinic and met Wael there, and was very involved in the delivery side of cardiac services in Cleveland, and was on the ACO board for a number of years as we struggled to figure out how to do care delivery in a broader sense. I've been in Chicago for about 2.5 years now and lead our cardiac efforts here. We're the largest delivery system for cardiac care in the Chicago area, which is a very balkanized market. But one of my focuses is to try to make the care delivery equivalent for all of our patients, regardless of geographic location. So across our 11 hospitals in the Chicago area, but we have patients from all 50 states and 20 countries that utilize our services. And we are looking to use the next generation of tech tools, which I know Will's going to talk about, to make that care equivalent. So I'm very happy to be here. I think this is going to be a really interesting panel, and thanks for having me join.
Tony?
So good morning, everyone. Thanks for joining us. I'm going to keep the Cleveland Clinic connection going. I was at the clinic for almost 20 years. In the finance area, I was the administrator and handled the debt. And I also led revenue cycle. My last year there, I was the interim CFO. And then I had an opportunity to continue the CFO role over at Medical Mutual. And I held that role for about 1.5 years. In the last 7 or so months, I've been and had the privilege of being the CEO. I'm the only payer on this panel, so I got to keep my eyes open, keep my head on a swivel on this end. But in all seriousness,
watch your wallet.
That's right. There we go. I think today's conversation is more about how do we collaborate better. I will tell you, with the experience of working at the clinic and understanding all about the provider side, I think that bodes well on the payer side. And how do we work and collaborate better? That's the only way we're going to manage this healthcare membership that we have. We have to be collaborative. We can't be at odds with each other. So I think, being the regional payer in Ohio, we have an opportunity to really make a difference with those providers, and we'll share some of those examples with you. So look forward to the discussion today.
Al?
Can anybody guess what hospital I used to work at? So I was at Cleveland Clinic for 25 years. The first half, I was actually a clinician. I managed 3 outpatient sports medicine facilities and was a certified athletic trainer, and actually used to work the sidelines with Dr. Barsoum here back in the day. And then I moved into supply chain, senior director of sourcing, value analysis, and procurement. I think the uniqueness of being at the clinic was very, very forward thinking. As accountable care organizations came around, they knew that we were going to have challenges with finances, as well as bundle payments started to rear its head. So we had some aggressive cost savings goals that we had to go after. So my team and myself were responsible for engaging physicians and designing processes that would assist in meeting the financial aspect of value-based care, with large initiatives that, like, over 2 years of trying to save $100 million. So we were pretty successful in doing some standardization around contracting and reducing unnecessary variation. Again, that's not for all organizations. That can be a challenge at times, but based on our leadership, we were able to accomplish quite a bit. I left Cleveland, went to Johns Hopkins for 4 years, oversaw sourcing and value analysis at Johns Hopkins. Very educational, as the Cleveland Clinic and Johns Hopkins are definitely 2 different types of organizations, but it was good to get that experience and get an appreciation for larger academic medical centers and how each one of them can function differently. A year and a half ago, I came to Vizient. Vizient is a group purchasing organization and performance improvement company. We thrive to maximize every dollar that providers spend. We have unique contracting opportunities. So I'm the vice president of category management, specifically over orthopedics. During my interviewing process, the one area they asked about is, where do you think orthopedics needs to go? And I said the non-acute setting. And 3 weeks later, they're like, why don't you work on that too, as long as we got you here? So super interesting. I think that it applies to all of us across the board here, as far as where healthcare is going and how we need to align as partners.
So Alan's picture isn't up there because last night, Tony and I were having dinner, and Tony said, Alan's in town. And I said, we should get him on the panel, because supply chain would be such a great thing to have represented here. So we called him up and we said, why don't you come down and have a drink with us? So he came down and had a drink, and I had to give him half of my steak. And then he agreed to join us today. So thank you very much. So let's kind of start with present state. And I'm actually going to start with Jason over here. Look, I think we all have examples of really good alignment between private docs, healthcare systems, ASCs, and payers. And we have examples that are really good and examples that are not so good. And I think Jason has kind of had the opportunity to see both. And I'd love to kind of hear from you around kind of where you think the present state is. What have you seen that has worked well? What are you seeing today that's working well? Obviously, you're actively innovating in this area today. And what have you seen that hasn't worked so well, where you see opportunity?
Yeah, great question. So a little bit more on my background. When I started off, I took a job as a fully employed physician and in a large multi-state healthcare system, integrated delivery network. And a few years into my practice, I must have missed a meeting, and they made me the chairman of the department. And then I must have missed another meeting, and I was the system director for MSK. And so
Surprise.
Yeah, exactly. So what became obvious when I stepped into the system directorship role was, from a macro perspective, at that point in time, it was very obvious to me and a lot of people, it's not that I was the first person to think this, that we had an unsustainable system within our own healthcare system, let alone nationwide. One of the things I talked about in an earlier panel is we have, everybody knows, we have $36 trillion of national debt, 30 trillion of which is on balance sheet. We also have $100 trillion of off balance sheet liabilities, which relates to entitlement spending. So this is not sustainable. This is becoming a national security issue. So clearly, healthcare being a large proportion of that, 25% of our GDP, this can't continue. And so when I stepped into this role as a system director, why I was interested in it was because we had an integrated delivery system where the health plan should be talking to the hospital, should be talking to the medical groups, and we could actually innovate there to do value-based care. And unfortunately, my conversations over the ensuing 5 years of being in that position went nowhere. And it became very obvious to me the inertia really that is embedded within the healthcare system. And so due to ongoing discussions with system leadership and whatnot, we just couldn't find a pathway forward to actually start doing true innovation in value-based care. And myself and 11 of my partners left employment en masse and opened up our own independent private group. And so putting on a different hat now and approaching the market from the perspective of, hey, we want to lead as it relates to value. We want to lead as it relates to aligning incentives. And really the only way to do this is to align incentives across all three areas of healthcare, the payers, the health systems, and then the providers. And so what's been interesting is that in our new situation, we've been able to partner with several area hospitals and health systems to deliver various degrees of kind of a la carte orthopedic services or run their service line or anywhere in between those two things. And so I've seen both sides of the coin. What is tragic for me is I'm sitting in some of these other discussion groups and hearing about systems that have been able to make that leap between being their own self-contained system and then bridging the gap towards reaching out with partnerships with area independent groups and whatnot. And I find it tragic to think that I was in a health system that had those tools to do that, and yet we couldn't make that leap. And I think moving forward, we're going to have to partner and have to find entities within the marketplace that are actually able to deliver on that ability to think differently and look forward and understand that look, the times are changing. No matter if we want to or not, it's going to be a forcing function, and we have to be able to adapt.
And Jason, just for a moment now, I mean, you've obviously found new healthcare system partners that are aligning with you. You guys are breaking ground on a new ASC. You've opened physical therapy, right? Office-based physical therapy. I'm going to go to Tony after this, but the idea of kind of office-based PT, ASC settings, right patient, right time, right provider, how much of that is playing a role in kind of your strategy moving forward as you guys continue to expand?
Yeah, it's a huge part of our strategy. And I think one of the places on the value curve where our practice has been successful is the only other option within our jurisdiction is to go into the big box health systems. And it's not a day that goes by where I don't at least hear from 4 or 5 new patients of mine that say, oh my God, thank God this is an option, because I was lost in the system and I needed a place that would allow me to come in, get my care, have it be seamless. I don't need a navigator to get me through the system. So it's been really refreshing to hear that. And speaking about Tony, I mean, last night, of course, I think one of the things that we need to do, no matter where you come at from, whether you're a provider, health system, or a payer, is understand that we have so much in common. I mean, I sat down with Tony and we immediately enjoyed each other's company, and I thought, damn, I was supposed to not like the payer guy, right? And so I think, if we're able to peel back some of those layers of what classically has been the relationship of being antagonistic, you realize healthcare is not a zero-sum game.
Mm-hmm.
It can't be. When we have to do this together.
Yeah. And, it's interesting because I come from an environment of being an employed physician for my entire career, and I loved it. I mean, it was a great experience for me. It was terrific. Doug, I think, falls in that same category. So there's clearly, I think, plus and minuses to both. But in the United States today, we see the majority of physicians today are employed, and that number has somewhat plateaued, but it's a fairly high percent. I see, my old medical school classmate there, Lou Bly, is an employed doc, and I see one of my residency classmates here, Scott Hannum, who is in private practice in North Carolina. So there's clearly something to be said for all of these different models. But when you think about it, Tony, and you're thinking about alignment and thinking about really meaningful change, especially for a company like Medical Mutual. Medical Mutual is in Ohio, 1.2 million lives that they cover. And I grew up in Northeast Ohio. So I grew up with Medical Mutual in my back pocket. It was truly kind of the neighborhood health plan that we all grew up with. And when you're thinking about making a meaningful impact to the community.
Mhm.
Is it easier for you working with private docs? Is it easier working with larger healthcare systems where everybody's kind of aligned? Does it really not make a difference one way or the other from your perspective? But what's the easiest path to alignment for you?
Yeah, the way I'd answer that is one, thanks for the question, and Jason, I enjoyed the conversation last night as well. Is I would tell you, when you deal with the ASCs, it feels like they're skin in the game. They understand the bottom line, and they're very sensitive to the balance of you need to treat the patient, but right setting, right time, right place. When you get to the bigger system, I think that gets a little lost. It gets lost in the sense of everyone wants to do the right thing for the member. No question about it. The payers do as well as the providers. But I think the size and scale, that's where that gets lost. So I think when you look at running the ship the most efficient way economically as it relates to the spend, Jason, as well as what's right for the patient, I think it's the ASC. For us to work with them, it's harder on the larger providers. And the reason is you have so many different departments that you work with. And I'll just give you historically, payer-provider relations is one that are the no trust. And it's always the managed care versus the contract teams. And all that matters is how much rate you get, so that when you get that rate increase from your payer, you walk into the board and you said, we got X rate and that's X millions of dollars to the top line. But I think what everyone is missing is truly the realization. What do you ultimately get paid for it? And I know there's a lot of myths out there as it relates to, or misunderstandings as it relates to what's the payer's role here. Our payer role is to pay the claims. That's what we're here to do. Now, we represent those that engage us. So the groups are the ones that determine the benefits. We just make sure we're aligned to those benefits and that the provider is following the rules that have been set on that. That isn't about denying it. So you always hear, well, the denials are at 20% or 30%. That's not a denial, that initial, that's a request for more information. It's not a denial. It's just we need more clarification. That's all it is, which leads us to we need to share our data. We need to have access to the EMR. Now, immediately when you ask a provider access to the EMR, they say, well, I'm not going to give you access to the EMR. And why is that? Because you're going to deny more claims. And I say, if the denials go up, cut us off, and I'll refund those denials. It's going to make us more efficient. The point I'm getting to is there needs to be trust within the systems. The data is so important for us to exchange that, and I'll give you one success example you were asking. Probably about 8 years ago when I was at the clinic, we said, we got to quit complaining about this administrative burden that goes on in healthcare, and let's do something about it. So actually we partnered with the regional payer MMO about how do we reduce waste. In the first year, it was very much about, well, my information's right, yours is wrong, typical. And then what they realized, the groups realized, well, these are my neighbors, my friends, our kids all go to the same schools. Wow, they're just like Jason and I just said, wow, we kind of hit it off. That's what happened. So that second year, it was about trusting the information and how do we drive for results. And over the last 8 years, tens of millions of dollars have been saved by reduced denials. Again, I'll call them initial denials, the request for information. Those final denials, it's probably less than 1%. So think about it, 99% is approved. Now there's mistakes made. That's what makes up the 1%. And you feel this trust about how do we innovate more together and how do we take and raise the bar. So that playbook is in place for us to take to other providers. What we have to do now is it can't take us 8 years because we can't do that to our members and our customers. We need to make this much more efficient. And so what we have to do is pivot to say the providers that understand that want to work with us, those are the ones we need to really move the needle with. The ones that want to still are kind of older school and transactional, it's going to take a little bit more time, but we need to get results immediately on this. So it's going to be what our approach is going forward, but it was wildly successful what we did the last 8 years at the clinic.
So you have a question?
How do you explain the lack of representation by payers at conferences?
I'm not sure I can answer that, but I would tell you, you invite me to any conference, I'll come, and I'll represent the payers. I just think I had Will and I were talking, and he said, "Would you be willing in my new role?" So I just took over CEO 7 months ago. Would you be willing to talk? And I said, "Absolutely. I'm happy to clear up any mess." I can't answer that, but I would tell you. Happy to join that. We got a great story to tell, but I think the story is about the partnership. It shouldn't be individual. It should be us together in these panels having that discussion.
Because they get a raw earful, an unadulterated earful about what our challenges
Sure.
are if they would just show up.
Yeah, and I would tell you, we always want to be better, and we want to hear how we get better. I don't want to hear what we do great. That's nice. We can have that, but we're always looking to innovate and do things differently, because there's so much opportunity and waste in our business. So certainly I'd love to hear more. We could talk afterwards. Love to hear what you're thinking and where we can get better at that.
I'll just add something to this. We've had a couple different sessions at different national conferences that where HOPCo's been involved in the session. And this is the third time we've asked somebody on the payer side to participate, and the third time they said yes right away. I honestly think that part of the challenge is us. We're not asking them often enough to participate, and I think that we have to take the lead in changing that. I think that really does make a difference, because your point is a fair point, right? Having the true 360 degrees of the payer journey represented is important, and we haven't really done enough of that. So I think it's a fair point. Doug, so Doug's a world-renowned cardiac surgeon. I'm not going to ask you about aortic aneurysms or coronary bypasses, but I want you to put on your value-based care hat. During your time at the clinic, you obviously played a huge role in the ACO. And the clinic model is an interesting model in that we have our main campus in Cleveland, our main campus in Weston, and then we also have hospitals that are kind of private practice, open staff hospitals where you can just get aligned and get privileges at that hospital and work at it. And we went through and built a care alliance. We built an ACO, and we aligned many private docs around Cleveland Clinic facilities and Cleveland Clinic sites. Walk us through a little bit when you were involved in that type of work. How did that alignment work out? Did you feel like we were genuinely changing clinician behavior to drive quality up and decreasing cost? And what kind of technologies were we allowed to share obviously in a legal way to engage these clinicians more heavily in the pursuit of value-based care?
That's a great and complex question. I think I would kind of pivot the name of the topic a little bit to democratization of expertise. The biggest challenge we had with the ACO was not improving quality for diabetes care to try to get the hemoglobin A1C under a certain level, or things that PCP groups are relatively comfortable with. Compliance with heart failure medication guidelines, like that's a big one. Lots of PCPs who were used to not treating such complex disease in the value-based care era became quickly cognizant of those things, because many of them are on per member per month plans. They don't want their patients admitted to the hospital, so they're incentivized already for that. The difficulty was in sort of the not bread and butter conditions that are a little scary to patient and primary care provider. And as we try to get, especially the non-aligned groups who might not have a friend or colleague that they could get on the phone and ask a question, we're much more likely to send a patient to an emergency room or get an expensive study for a condition that maybe didn't need it. And I'll give you one example from my world. You mentioned aortic aneurysm, but lots and lots of people have an incidental finding of a small aortic aneurysm because they get a CAT scan for something or an ultrasound for something. Most of them just need yearly follow-up or bi-yearly follow-up or nothing. But a majority of those patients within our ACO system were being referred for a CT scan, a cardiology consult, an ER visit. And those are all very expensive pieces of the pie and unnecessary. That's not guideline directed care. So one intervention we made, and it's interesting, the outside payer component of this was we instituted an e-consult process whereby anybody in the network could send essentially a one-liner message in the EMR. Hey, I've got this patient with this problem. What do I do about it? And it got sent to a pool of experts depending on the diagnosis. So there'd always be somebody on call, an answer come back within 24 hours. And it could be, this is bad, send them to the ER, send them to see me in consultation, or most often, get this study and let me know when it's done and I'll look at it. And so to make that operational, we had to incentivize the primary care docs to use the system. And that essentially came to their usage over the course of the year and how that played into their piece of the reimbursement. And then for the specialists, you got to give them credit for the work. So we essentially gave them RVU credit for the free work that they were doing to do e-consults. A win on both sides, dramatic reduction of resources, particularly in imaging for some of those diagnoses. And that actually led to a partnership with one of our payers where they came to us and said, we're spending a lot of money for aneurysm care when people go to a low volume hospital and they have bad outcome. And how can we figure out how to get people at least an opinion from you guys? And so we developed a way to look at that point without EMR data, but across their claims data to see who might have a need for this, built an algorithm, and we messaged out to hundreds of thousands of patients to say, hey, you might have a risk of this. Can we do a quick review of your case and provide you with some free care? So what this gets to, I think, is, and we're going to talk about sort of future state and creativity. To me, if you get back to the patient and think about, can we get you the most efficient access to the person who is the highest level expert at taking care of your condition? It probably doesn't mean going to see them in person in 2025. It might mean an AI algorithm reviewing your imaging study and flagging it, and then somebody at a high level reviews it and says, hey, this is what should be done. And then we throw it back to the PCP in partnership with them. Doesn't cost them anything, doesn't cost the patient anything. Eventually, wearing my Northwestern hat, it's going to get me a referral for an operation. And we've done the math, and you can do that sort of free early stage care hundreds of times and break even with one procedure. So I think that's just an example. We were talking before the session about how do we get creative about reducing cost. It's the inefficiency of multiple studies, multiple providers, multiple trips, multiple days lost work that is inherent in the current system. I think some of these are relatively low-hanging fruit, but we have to get creative about the incentivization. We have to incentivize everybody, patient, provider, payer, to make that all come together.
So, Alan, I'm going to make you earn that half a steak now.
You get a half an answer.
So, one of the things that I hear frequently, at HOPCo, we work closely with healthcare systems. And when we're working with them, we will frequently help them out on their supply chain side. Mm-hmm. And there's, especially in open staff systems, there's always this concern that, well, if we go to a single vendor or a dual vendor system, we're going to lose our doctors, or, they're really committed to this system versus that system, and it's a problem. And so it can be a real divisive thing, but it could also be a real uniting thing. And one of the things that I remember very vividly about working with you is that you came up with a methodology around engaging every clinician in the process of supply chain management and procurement, which I think was unique. It was different, and it was wildly successful. We rarely, I don't know that we ever lost a doctor from one of our private hospitals because of a supply chain decision that we made. Now you're at Vizient, a performance improvement company, right? I mean, and managing, in essence, through Vizient, all expense other than salary, wages, and benefits. Mm-hmm. Pretty impressive. So how do you think about the role of supply chain in terms of improving alignment, as opposed to the narrative, which is, if you make any change, it can only make things worse?
Yeah, great question. I think every organization has a different level of maturity, some obviously more than others. So we had the pleasure of having great executive leadership within Cleveland Clinic who empowered us and supported us to come up with an objective, clinically focused process first, cost second process. And so therefore, I think to Will's point is that when you have a mixture of private practice and employed physicians, if you were to just take the employed physicians and put them in a room and make a decision, you're going to disengage the private practice physicians. And honestly, they have as much knowledge and value, potentially have done, clinical research that can add to the conversation about what's the best methodology for contracting. So two parts. One, inclusion, and when we did total joints at Cleveland Clinic, I think we had 42 surgeons in the room, and that may seem like a lot, and you would say, well, it's tough to come to a decision with that many surgeons in the room. Not going to say that it wasn't, but I think it was appreciated the fact that we respected the private practice docs as much as the employed physicians. Now, in partnership with them, we facilitated the process of what do you need to make a decision? So if we're going to reduce unnecessary variation, what does that look like? So obviously definite relevant clinical data. And then we had a robust process where we looked at product attributions and matched categories of spend to say, here was the match rate of technology from historical spend with all these suppliers. Here's what happens if we standardize. And so engaging them in the process, again, twofold. One was I'd rather have the loudest surgeon in the room right out of the gate, because if not, you're dealing with about 9 months worth of emails and nasty phone calls. If you put them at the table and you at least give them the chance to speak their mind, I think that decreases it quite a bit. So I think we got a lot of buy-in to the process. And the other aspect would be is aligning the physician's leadership goals with the organization. I can remember us going from, we had 2 vendors in open spine implants, and we were debating to go to 1. And our chairman actually shared in the administrative budget goal of cost reduction. And we presented all the clinical information that the team had asked for. And he turned and he said, ladies and gentlemen, unless you can tell me why we can't go to a 1 supplier for clinical reasons, he says, we're short on our budget and we need to drive towards that. So I can't say enough that that was a valuable lesson in seeing how to move the needle by aligning those goals and objectives. But I don't want anybody to think that we went to the lowest cost option. It was truly vetted clinical first, always cost second.
Oh, makes sense. Jason, can you say something?
Just something to add. I think from the perspective of aligning all these various entities, I think it never is overstated enough that really it requires a different way of looking at financials and accounting. So as an example, when I was in the large health system, it came down to a conversation between, hey, and again, this is integrated network, right? So we have the health plan at the table saying, hey, if we start moving these cases to an outpatient surgery center, this is beneficial from the health plan perspective and surgeons are happier and so on and so forth. And yet we have hospital leadership in the room who are incentivized based upon margins that they create at the hospital, saying, well, you can't do that because my productivity bonus at the end of the year will go down. And it seemed so simple to say, well, wait a minute here. We're a health system. Can we not just change the way that we account for this and use a broader context of saying, what are the overall financials of the health system? And thereby you'll be bonused based on that. And that conversation went nowhere. And so I think it's almost so, we were saying last night at dinner, it's almost so obvious where some of these solutions exist. And yet there's this inertia to all the different parties, right? Providers the same way. Well, I've always used Zimmer Biomet to do total knees, and I can't possibly think of doing anything different. Well, everybody has to start thinking out of the box. But I think one of the keys to alignment is to say, hey, let's all realize some type of financial accounting benefit if we're going to be saving the systems and the payers and everybody for spending less money. We should all benefit from that if we're doing this together. And I think it's not always all that difficult, but it requires a little bit of out of the box thinking from the various stakeholders. So,
Tony, you touched on technology and using technology to better integrate. One of the things that struck me, I was reading an article this week, and IBM just announced that in the next 3 years, they're going to be releasing their next generation quantum computer, which will have 10 to the 48th power, more computing ability than their present quantum computer, 10 to the 48th power, which is the equivalent of 20,000 times more computational ability than every supercomputer on Earth today. That's going to be out in 3 years. I mean, it's an unbelievable number. I remember Toby Cosgrove used to say that medical information doubles every 30 days. today, right? When you think about everything goes into an EMR, all the publications that we have, right? How do you sift through that, right? The most advanced clinician, the most advanced CFO, the most advanced healthcare administrator in the world can't possibly come close to keeping up with 1/10 of 1/1,000,000th of 1% of that information. It's just not possible. So let's just think for a moment about future state and the value of AI, the value of supercomputing, the value of interconnectivity between a payer, a healthcare system, a provider, right? Where do we go moving forward compared to where we are today? Tony, you want to start?
Sure. No, I think it's an exciting time on that. Let's just stick with AI for a minute. And it's just advancing every single day. So how we're incorporating AI is on the prior auth, which I know is very sensitive to everyone in the room as it relates to, why do you need these authorizations? And just understand, step back for a second, the groups we represent, it's contracted, right place, right time, right amount, right? But we can use AI to expedite the approvals of that. And we're doing that today. So we're already seeing the benefit of that. So that benefit goes all the way back to the member, because the members are the one that's saying there's something wrong. They need to have an MRI and they're worried about what that means. They need to have a surgery and they're trying to schedule their kids to be watched and so forth. It's very, very stressful. And then you throw on top of that, well, the authorization wasn't approved. Just sign this form that says you'll take on financial responsibility if it's not. Let's add a little bit more stress to them, right? That's not the right thing to do, and that's not what it's about. So we'll have AI approve those that need to be approved. That frees up the time for something that's not approved initially, might need some additional questions, might need peer-to-peers. Now we have more time to actually process those more quickly. And so we will never, ever, ever use AI to deny a claim, ever. What happens if it meets a parameter that says, hey, listen, something seems odd on this, we then bring in all the physicians and the nurses to then evaluate the claim and have the conversation. So we're only going to use it to benefit to expedite the process, not to slow it down and or to deny anything. So I think that's just an example of one of many things that we'll be able to leverage AI for. Then we'll use AI even within our own teams to make us more efficient so we can cut more cost out. We got to cut costs out of our side as well. This isn't just the provider side. I mean, the provider side, I said that 60% of those are in the red. There's take the nationals away just because they have so many other things that add to their bottom line. For a regional payer, like our margin being a mutual is, if we're 1% margin, that's you're doing cartwheels on that, right? Because that's how it should be. We're here to pay these claims and get the health of our members and your patients taken care of. That's what we want to ultimately do and leverage the technology going forward.
Doug, maybe touch a little bit on, the interconnectivity that we see, with a common EMR, for example, appropriate documentation, and maybe even sharing data back and forth between a payer and a healthcare system, through an ACO type model.
I think that some of the tools that the AI tools that Tony just described are going to make this a lot easier. It's not just for one person in a silo reviewing a stack of data. Fortunately, the EMR interconnectivity has gotten a lot better in the last few years. And with tools like Care Everywhere and Epic, we can look at outside records. What's often missing is sort of the hard ground truth data. We have to still go directly to other hospitals to get the imaging, but increasingly we're not having to send CDs back and forth. I mean, those could be transferred electronically, and I think that's going to get better. But there's no question in my mind that the two things that are going to be transformative are the wide availability of sort of ground truth data, combined with the ability to sift through it and get to the level that's still the currency of medicine. Will and I've been talking about this for way too long, but diagnoses are the currency of medicine, right? They drive all of the billing. They drive the ICD-10 codes that drive in hospital. They drive the DRG, right? And there are a bunch of supporting data, but it's not an ocean of data that drives payment or quality assessment, right? It's a relatively small number of data points. They just have to be accurate. And I think one of the things that will be easier to do as we move into this era where some things are AI assisted is to do the vetting process, right? Is the final list of diagnoses on this patient accurate? These days, it's probably 70%, right? There's a bunch of good data out there that says that the accuracy of diagnostic codes in a hospital chart is about 70% if you look at the Medicare rules. That's a nightmare for the payer. It's a nightmare for us. We're one of the few specialties that has publicly reported outcomes, right? You can go to Consumer Reports and see what the quality of a cardiac surgery program in the United States is. So what goes out the back door, whether it's for payment or quality and all these sort of parallel data streams, is hopefully going to get increasingly more accurate over the next couple of years. The more accurate it gets, the less often we have to do denials. Maybe denials management will go away. If we and the payers can say, hey, we both agree this is the validated list that our system generates, there's no reason for anyone to look at it. Or maybe it's a 1% look, not the 1,000 people that used to sit in the Cleveland Clinic basement and do record review, right? So when I was working on documentation, and Will and I spent a lot of time on this very dry subject, we looked at a few patient charts and found that the amount of time that the administrative team was involved in an inpatient chart was 3 times as much as the clinical team. I mean, that is insane waste, right? When you talk about the cost of the healthcare system. Right. So I'm very optimistic after working on some of this stuff and not making a lot of progress for years, that we're at an inflection point where the tools that are available are going to let us get much more efficient. And while people are all worried about their jobs being eliminated, I would much rather we flip someone's job from reviewing records to dealing directly with the patient. I mean, that's where the human interaction makes a lot more sense. So let's take our nurses out of the back office and get them out in front. And I think that's what these tools are going to let us do.
So I think we're supposed to be done now, but before we say goodbye, I still had like 10 more questions to go through. Any questions from any of the audience members before we?
I thought it was interesting that you guys talked about having dinner last night. You gave an example of the way that you guys had movement and alignment, because that they know the person next to you has family or neighbors and children.
Mm-hmm.
As you start to use more data, what we worry is that you actually lose that personal touch. So how do you kind of marry those two different things?
So you're talking about the personal touch with us?
Yeah.
Yeah.
I mean, I think the more, like, if you like each other, then it's easy to move forward. If we don't have a reason to meet each other.
Oh, I got you. Yeah. I would say if we could get through this administrative stuff, I think it just leads to more innovation. You continue. You already started the process of forming that relationship. It only gets better, and then you get more, and I would say more innovative over longer term. I don't think it slows down. I only think it gets better, because then you're sharing best practices, and how do you continue to drive to seeing more patients and eliminating waste.
You had a question?
Actually, 2 questions. One, do you see a role with payers in terms of helping revenue cycle management with providers, both from the institutional level and private pay?
So I did lead revenue cycle at the clinic. And so one of the things that we just came up with is, why aren't we getting in front of the providers because I have a few of the team with me, with some of the wins that we've had over time, so that we can help educate those on the revenue cycle side of these smaller hospitals of what best practices are. We literally just had this meeting about a month and a half ago, where we're thinking the same way of, that's just sharing best practices. So spot on with that, and we're starting to do that. It's been very well received, by the way.
I'll make one quick comment on revenue cycle. Our head of revenue cycle at HOPCo, a woman named Jen Worthy, is on LinkedIn, and she posted a great article about a week ago on LinkedIn, and it talked about the difference between things that are hard and things that are complex. And she said, look, revenue cycle is clearly complex, and the way you fix a complex problem is with process. Right. And that's where AI and computing can be very helpful. The way you fix a hard problem is with grit. Right. And I think to a large degree, we have tried to fix revenue cycle with grit. And that is massively human capital expensive, as opposed to a process which can be simple and automated, but it takes a complex issue and makes it more manageable. Any other questions? All right. Well, thank you all so much for coming. I hope you enjoy the rest of your time.